First, no disclosures. And we're going to focus on three main goals in this talk today. So number one is we're going to work on recognizing some of the common complications of cerebral palsy. Two, identify in terms of which patients are at highest risk for different comorbidities. And then three, focus on, and this will be more short, but focus on recommending next step interventions. And this will be a recurring theme throughout the rest of the day, is now focusing on interventions for CP. When we talk about comorbidities, I just want to back up and talk a little bit about four main types of comorbidities that we can have. So in general, when we talk about comorbidities with CP, number one is you can get primary comorbidities. So that means you've got an injury to the brain or a change in the brain, and that directly causes problems with something. So for instance, if you have an injury to the motor part of the brain, you're going to have problems with motor control. Secondary are then downstream effects from that. So if you've got problems with motor control, for instance, motor control with your mouth or with your throat, you could have problems with speaking or swallowing. Then we talk about next associated comorbidities. So these are things that are maybe not caused by the same brain injury, but are very common in patients who have cerebral palsy. So these are things like intellectual impairment, epilepsy, visual impairment, hearing impairment, and these are things I'm going to focus most of my talk on today, as well as comorbid conditions. So things like ADHD, learning problems, asthma. Breaking this down, we can really figure out who's at risk for different comorbidities based on these three main things. So number one is etiology. So we've kind of, in our first talk today, talked about how a lot of these different etiologies will fit cerebral palsy, but some of these different etiologies predispose you to different comorbidities. So things like hypoxic injury, strokes, certain infections, kernicterus, brain malformations, metabolic, all have associated comorbidities that go with that. Second, your comorbidities may change based off of either the type of cerebral palsy or the imaging characteristics. So, and these kind of go hand in hand, because based off of what is involved in the brain on imaging, you may have a different type of cerebral palsy, and thus you have a different type of comorbidities associated. And then lastly, motor function. So the degree of motor function is very much tied with what is your risk for different comorbidities. This is just looking at the brain, looking at the homunculus. And so kind of understanding what people are at risk for, has a lot to do with location. A location isn't perfect, but I tell patients sometimes that cerebral palsy is like real estate. It's all about location, location, location. And so legs can be involved, depending if you're more in the medial part of the brain. The further part you get out, you get more arm and face and mouth involvement. So you can imagine some of the downstream effects of those things. I love this schematic. I think it kind of, it is a little simplified, but it definitely shows that depending on where the brain is involved, you can get different types of CP and different types of symptoms. So hemiplegic, and we'll break this down a little bit further, but hemiplegic cerebral palsy, one part of the brain is affected. So think of something like a stroke. That means the other side of the body is what is going to be affected, left side of the brain controlling the right side of the body. Spastic, so the most common we'll see is diplegic. So this is affecting both legs at the same time. So again, remember that homunculus, it's going to be more in the medial part of the brain affected. Quadriplegic, so these are patients that have more global involvement. And then, the category of dyskinetic. So these are more of the deep brain structures, so things that aren't controlled, or things that are responsible for your motor control. So thinking about how you move. And these can be patients who maybe move too much. So chorea athetoid, where they have constant movements, or dystonic, where they have intermittent episodes of abnormal tone. I think the term dyskinetic is a little bit easier as an overreaching term. And then if patients have the balance center of the brain, the cerebellum involved, they may have more of an ataxic CP picture. This is a wonderful schematic from a paper in 2012 that really nicely breaks down, based off of cerebral palsy, how many different comorbidities are involved. So 3 out of 4 patients may have pain, and it can be higher depending on certain studies, intellectual impairment, verbal problems, sleep issues. So let's start with intellectual disability, and we'll kind of look at how the different types of cerebral palsy change this based off what's going on. So first, as Dr. Harris really nicely talked about the idea of what disability, I'm just going to use the IQ quotient here, just kind of as a broad overview here. And it's expected that the IQ less than 70, which is the adult definition of intellectual disability, is estimated to be about 38 to 52%. One thing that I really want to be a major takeaway as I talk on this subject is that it's possible this is an overestimation. Because if you imagine the way we do IQ testing, it has a lot to do with how you type, how you write, how you do things. And so if you've got pretty severe motor impairment, particularly patients who may have dyskinetic movements that make it hard for them to move, they may do worse on IQ testing that isn't necessarily reflective of their cognitive function. So not every patient that you interact with who has CP has intellectual disability. So that's important as you're talking and interacting with them. There are adaptive testing that you can do. So that's really important if you're going to have thorough neuropsych evals to try and help patients out. And keep in mind that intellectual disability is much more common in 3 main groups. So patients with epilepsy, which we'll talk about, quadriplegia, so again, more of the brain involved, so thus it's more likely that you have intellectual disability. And then again, poor gross motor function, again, suggesting that more brain is involved. So breaking down this schematic one by one, let's talk first about our patients with hemiplegic cerebral palsy. So again, this is a nice example of a in utero stroke. So this is affecting the left side. So this would be a patient who would have right body involvement. So what do these patients look like over time? Well, many of them actually have normal cognitive function. About 85% will have normal IQs. And what's really interesting is there's no difference in IQs if the left or the right side is involved, and if they're preterm or term. So these tend to not have any changes in this. But as I mentioned before, epilepsy is an important thing because patients who have seizures, particularly refractory seizures, tend to have lower IQs. Now, even though they have normal IQs, they may still have other learning impairments. So think problems with visuospatial cognition, problems with acquisition of visual imagery, so how you see and interpret things, and then executive function. So how do you make decisions? How do you plan? How do you take care of yourself? A lot of things that are important for patients to have, be able to be freedom on their own. One thing that I really want to hammer home, and it is difficult, especially as we are counseling families long-term what to look out for, is that contrary to adults with focal lesions, the left hemisphere, so most people, their talking center in the brain is on the left side. Patients who have left-sided injuries early in life almost always spare language. This is because babies' brains are neat. You have something called neuroplasticity, which allows the brain to rearrange early in life. That's something that as adults, if we were to have a stroke on the left side, we don't have that luxury of the brain reorganizing. So even though patients have left-sided lesions, they may actually have normal speech long-term because that speech center gets reorganized to the right side. Diplegic cerebral palsy. So these are patients, and I'm using an example here. Most of the time when we think about diplegic cerebral palsy, we're thinking of patients with something called PVL, and that's periventricular leukomalacia. That means periventricular, around the ventricles, around the fluid sacs, leukomalacia, scarring in that area, white matter scarring. And so again, many of these patients may have normal IQs, so somewhere between 67 to 78%. Now, if patients have a different cause other than periventricular leukomalacia causing their diplegia, that they actually have higher risk of a lower IQ. And even though IQs are normal, just because of that back center of the brain being involved, they may have other issues. So things like impaired visual spatial reasoning. This has to do with where that injury is. So some of the problems being able to look at things and interpret what you're seeing may be difficult. And this isn't always perfect, but oftentimes the extent of injury can correlate sometimes with how severe their intellectual disability may be. And then going to quadriplegic cerebral palsy. So this is an extreme imaging example, but a patient with end-stage cystic encephalomalacia, so that means injury to the whole brain causing cysts in the brain. This was from a patient with hypoxic injury at birth. And these patients, as you can imagine, because of the extent of brain involvement, tend to have much higher risk of intellectual disability, almost all patients. Again, keep in mind though, this may very much be an overestimation because of how we're testing that. And again, correlates with the degree of injury. Now, probably the most diverse group here when talking about comorbidities is our patients with dyskinetic cerebral palsy. One of the reasons for that is it's very diverse in terms of where the injuries are and what causes it. So I've got two examples here of two different patients, one with a patient with hypoxic injury. So again, to that basal ganglia, and this was a patient with kernicterus. So that means high bilirubin at birth causing injury to the brain. Big variability. These patients can have, depending on studies you look at, IQs can range anywhere from 25 to 70% less than 70. So a huge range of what these patients can look like. And what's really key though to recognize is that many will have normal cognition, even with really severe motor impairments. That's because the deep part of the brain's involved, not the cortex, not the thinking part of the brain as much. And so recognize that a patient may actually have much higher intellect than you may think the first time you examine them just because of their motor impairments. And a lot of studies have shown that even in patients who are nonverbal, if you use adaptive functioning, adaptive testing, they may have normal memory, normal language, normal executive function, normal visual perception. So there's a lot of other domains involved that they have normal intellect in. So what do we do about it? How can we intervene and try to maximize function for our patients? So lots of studies have shown the benefit for early motor intervention, but there have been very few studies that have actually been done showing, okay, if we do early intervention, how does that affect intellectual impairment long-term in patients with cerebral palsy? Regardless, the most important thing is what Dr. Harris said, recognition, early referral, early intervention, because that makes a big difference. With that, because epilepsy is so tied with intellectual function, one of the best things that we can do for intellectual development is to identify seizures early. So epilepsy is estimated to occur in anywhere from 30 to 50% of patients. These seizures tend to be associated with much greater cognitive dysfunction, more severe behavior problems, and much greater burden of care. So a lot of patients will say, you know, if you ask them, if I can make your life better, what's one thing I can do? You know, even if they have severe motor impairment, many times it's the seizures that keep them from being able to go to school or be able to go to friends' houses or have the quality of life that they want. It creates a higher burden of care and a lot more stress on families. Risk factors for patients with epilepsy. So it's much more common, like I said, in patients with quadriplegic cerebral palsy, but also dyskinetic cerebral palsy. Patients with intellectual impairment, so the more seizures you have, the worse intellectual impairment you have, but also vice versa, if you have intellectual impairment, you can have more seizures. Patients who have severe visual or hearing impairment have higher risk of seizures, and then of course patients who are non-ambulatory, so implying more injury to the brain. So this, again, just breaking that down. So we see it, again, higher in patients with dyskinetic, patients who aren't walking, and patients with intellectual disability. So epilepsy and cerebral palsy, how do we diagnose it? So there has been no evidence to suggest screening EEG. So, but there are a couple of tips that I want to give you in terms of who to identify. So first, patients with any concern should be referred to a neurologist. Some things that are important to realize, seizures can look very different, particularly in young kids or neonates. So identifying patients with staring spells, patients who aren't responding to touch. Infantile spasms are something that are much higher risk in patients with cerebral palsy. So patients who are having kind of quick jerks, particularly in the morning, that come in clusters, those are something that should be evaluated immediately at an emergency department, not a referral to a neurologist, but immediately to the emergency department. Other things that are helpful, if you're noticing that patients are having regression, particularly in speech or language function, that is something to have a very low threshold to consider EEG, because that can sometimes be seizures occurring in sleep. Treatment is variable, but some of the things we know about treatment in epilepsy: one, it's important to treat early, but two, oftentimes these patients require multiple medications. It's less common that they only are able to be on one medicine. And there are other things that can be really helpful with treatment. So surgical interventions, depending on where the injury is involved. Sometimes patients benefit from surgical options, as well as diet therapies. Speech. So speech is important, can affect many patients with cerebral palsy, and it occurs for a number of reasons. Speech can be limited by dysarthria, so slurring of your speech. That has to do with motor control. Language delays or problems, so based off where the injury is in the brain, causing language delays, and patients with lower cognition may have speech issues. One of the things that gets unrecognized is the problems with motor development and how that relates to speech as well. So patients with gross and fine motor delays, they're not going to be able to gesture, they're not going to be able to sign, they're not going to be able to write. So that can cause other problems with communication. Patients with spasticity often have worse speech than patients who are dyskinetic. And one of the keys is that patients, many studies have shown patients not talking at 2 years of age often go on to have severe speech and communication delay. It doesn't mean that they won't speak, but it often means that they will have much trouble speaking. Pain. So Dr. Harris talked about pain. I'm going to go just a little bit more further on this, because I would argue this is probably one of the most under-recognized aspects of care in patients with cerebral palsy. There's a number of reasons for this. One is that a lot of our patients have difficulty communicating with us. It's also because a lot of these patients have multiple possible etiologies. So it becomes really tricky in terms of, okay, if we have recognized pain, how do we figure out what the cause of the pain is? With the communication difficulties, sometimes we don't know that patients actually have pain directly. They're showing us in other ways. So that may be behavioral problems, behavioral impairment, sleep issues. Oftentimes sleep pain is related to that, particularly in young kids who haven't been diagnosed with cerebral palsy. That can be a clue because of spasticity or muscle spasms happening at night. In adults with cerebral palsy who can communicate, 60% of them will self-report pain. As you can imagine, these are patients who have more function, who are able to discuss this. So this is probably a big gross underestimation of the patients with pain. This is a happy patient with pain, but as you can see, there are multiple different causes. So number one is bone problems. So patients with hip dislocations, patients with fractures can certainly be a cause of pain. This is a little debated, but patients with other bone area abnormalities such as scoliosis, muscle spasms and muscle tones. So patients that are really tight or having muscle spasms can often cause pain. GI disturbances are a major cause of pain in kids with cerebral palsy, particularly constipation as well as esophageal reflux. Both of those can be big keys. If I have patients who come in to the hospital with cerebral palsy who have pretty significant pain, constipation is one of the most important things to be evaluated for. And then probably the hardest to both diagnose and recognize is neuropathic pain. So that means pain coming from the brain itself. This can be a difficult thing to diagnose. It can be a difficult thing to recognize, but it's also important to rule out other potential causes. And pain goes so much in terms of causing these other issues. So as I alluded to, mood changes are really common in patients with pain, sleep issues, and this leads to patients not wanting to be as active. So they don't exercise as much, they don't move as much, they don't go out and do things as much because of their pain. And a lot of parents and families and patients will say this is a big contributing factor to their perceived version of their quality of life. Talking about visual impairment, 75% of patients with cerebral palsy will have some visual acuity issues. It is an important thing to recognize early and can be difficult to recognize early. A couple of risk factors are patients who have bilateral brain involvement, more likely to have visual impairment. Patients who have occipital lobe involvement, so that's the vision center of the brain. Patients with brain malformations, and then torch infections. So we've talked a little bit about rubella or CMV, those toxo, those are ones that can cause visual problems and can be difficult to detect early. Kind of breaking it down in 4 main groups for visual impairment. One is functional vision. So patients who have decreased visual attention, so it's hard for them to focus. So functionally, it makes it difficult to see. Hand-eye coordination, as you can imagine, if you've got motor impairment, it makes it hard to have good hand-eye coordination, and that can actually have downstream effects in terms of the vision, and then just poor visual skills in terms of how the eyes track and communicate. Then you can get problems with the eye itself. So refractory errors such as amblyopia, much higher risk. Patients with optic atrophy, so patients with severe brain injuries or patients with brain malformations that cause optic nerve atrophy, that can cause problems with vision. Retinal abnormalities, so torch infections, for instance, some of them can cause cataracts, so problems with the eye itself. And then depending on where the brain's involved, visual field defects, so parts of the vision are cut off. Then you can have problems with how the eyes move, so strabismus, so that's skewing of the eyes, and that is something that can happen because of the way the brain is communicating, or it can happen for other reasons as well. And then nystagmus, so this is the brain correcting where the eyes should be, and sometimes this can cause jerking of the eyes, movement of the eyes, and it's important to look at that and recognize. And then you can have additional deficits. So I talked about cortical visual impairment, developmental delays, or patients who have sensory problems. Comorbid autism can cause difficulties with being able to see. And then lastly, we'll talk about hearing impairment. So hearing is important because this impacts everything we do: speech, language, cognitive, and psychosocial development. So being able to hear is important for kids who are trying to grow and learn. It plays a big role with intellectual development. Occurs in about 12% of kids, but about 2 to 5 have very severe hearing impairment. If patients aren't speaking or are delayed, this is the number one thing to first evaluate as a pediatrician is there signs of hearing impairment that we haven't picked up on. All of these patients with speech delay should undergo a hearing evaluation. And causes can be very different, but a couple main ones is different congenital infections. So thinking about CMV, thinking about patients with very severe hypoxic injury to the brain, they're higher risk for hearing impairment. Patients who were born with very low birth weight, so think about kids who were born premature. Patients who required ECMO in the NICU, patients who had neonatal meningitis, or again, kernicterus, high bilirubin levels can cause problems with hearing. So what do we do about this? How do we approach treatment? I'm going to kind of just put this out here because we're going to touch on this throughout the rest of the conference today. And I specifically didn't mention physicians here because I really wanted to highlight the importance of early intervention with our different therapy services. So our First Steps program here in Kentucky, the early intervention program, getting patients involved as quickly as possible for evaluation. Treatment serves two purposes. I tell families that not only is therapies helpful for treatment in terms of making things better, sometimes therapy is also another diagnostic tool for us where therapists are spending more time with patients. It may give us a better sense of their impairment. So physical therapy, occupational therapy, speech therapy, developmental intervention, vision therapy. And then patients who go on to develop some of these behavioral problems, psychology and behavioral therapy are very important thinking about their long-term treatment plan. So in conclusions, as I talked about, cerebral palsy can have other neurologic manifestations other than motor. So it's important to think about these and screen for these. They're often caused by what type of cerebral palsy, the area of involvement, and the degree impairment. And then in thinking about treatment, it's important for early recognition and intervention. That is key.